Atezolizumab plus Bevacizumab is approved for the first-line treatment of hepatocellular cancer. So I think almost for a decade before 2000 or so, we were using basically only one drug called sorafenib for first-line treatment as a systemic therapeutic options for patients with advanced hepatocellular cancer. And then I think it was presented in actually starting from 2020, and then the subsequent presentation called I Am Brave 150 clinical trial. So this is a phase 3 trial which randomized patients to either sorafenib or atezolizumab plus bevacizumab combination. And this trial accrued over like 500 patients or so, and looking at overall survival as a primary outcome. And this was the first time a combination regimen, or any drug for that matter, actually beat sorafenib in the first-line setting. So there, the typical survival with sorafenib was about 13.2 months in this clinical trial as a standard of care group. And then atezolizumab plus bevacizumab was over 19 months. So based on that trial that established atezolizumab plus bevacizumab as a first-line treatment options. In addition, the response rates were very high as well. With sorafenib was about 10%, and with Atezo-Bev about 30% in these trials. Most of the patients with hepatocellular cancer or HCC have cirrhosis or underlying liver dysfunction. And it is caused by various factors like hepatitis, alcohol, fatty liver disease, or what we call it MASH now, metabolic associated steatohepatitis. And these patients also have what we call competing mortalities. So they can die from obviously their cancer or hepatocellular cancer, but they can also die from liver dysfunction or worsening of liver function. And then there are various scores that have been developed to predict mortality or risk of dying because of the liver dysfunction. And there are MELD score, then there's called Child-Pugh score, and now more recently we have been using ALBI score. So typical about Child-Pugh score, it includes 5 factors, 3 lab abnormalities, which are like INR, bilirubin, and albumin. And then there are 2 clinical factors, which includes hepatic encephalopathy and ascites. And what this does is it takes a combination of these 5 factors and score from 5 to 15, lower the score is better. If you look at all the clinical trials, especially first-line trials, they actually only include patients with the best liver function or Child-Pugh score of 5 or 6. And more recently, people have been using more ALBI score, which is basically take into account only 2 factors, albumin and bilirubin. But there's a calculation, so you have to put those numbers in the calculator as compared to Child-Pugh, which you can calculate in your head if you know all these factors. So there's a difference. And people have found that ALBI score is not only as good, but probably is better than Child-Pugh score in predicting that mortality or predicting benefit. One of the things with the ALBI score is this very, very objective measure, right? So you have the albumin level and bilirubin level, you plug that into a calculator, you get the result, as compared to Child-Pugh, where there are 2 clinical factors like ascites and hepatic encephalopathy. And although there are guidelines, but could be sometimes subjective whenever we have a clinical factor in place. So as I said, so in the I Am Brave 150 clinical trial, they only looked at patients with Child-Pugh purely, so with the best liver functions, where they found 19 months. So we did this kind of a retrospective, one of the largest multi-institutional study, looking at all patients with hepatocellular cancer who received first-line treatment with Atezo-Bev. And we had about over 300 patients, 322 patients from multi-centers, where they were treated for these patients. And we looked at all kind of Child-Pugh status. So again, typically looking at Child-Pugh A, we found the median survival was 21 months, and Child-Pugh B7 was only about 9 months. And then Child-Pugh B8, B9, or even C was even worse, and about 4 or 5 months actually. And some of this is indicative of the, as I say, underlying liver dysfunction. What's happening is that patients with, say, Child-Pugh B8 or even higher score, their underlying liver function is so bad that they are dying from the liver function. Even if you are able to control their cancer, they do not benefit a lot with anti-cancer therapy because of the progression in the underlying liver disease. So I think the more unique aspect is Child-Pugh B7, where there is no clear guideline as to in terms of treatment because there's no like trial or data. So this is one of the first study that provides data that in Child-Pugh B7 that using Atezo-Bev, at least we're looking at the median survival of 9 months. So in that population, even though it's not great or it's not as much as Child-Pugh A, but these patients do benefit from treatment. So in our study, as I said, the Child-Pugh A was about 21 months. Child-Pugh B7 was 9.1 months. And if you go less than that, and even Child-Pugh B8 or higher, the benefit was even less. It was about 4.7 months or so in the total of the median survival. And what we found is it progressively keeps getting worse. So like if you're just looking at small cohort or Child-Pugh B8 is 5.5 months, you go to B9 is 4 months. But overall, if you combine B8 to C12, there's about 4.7 months median survival. So it's a huge difference between going from A to B7 to B8. So we think in 3 distinct groups, so Child-Pugh A, B7, and then B8 to C12 or something. The biggest problem is their underlying liver function. So because this is a worsening liver function, they're basically dying from their liver disease. So even if you're able to control cancer with some sort of systemic therapy, it doesn't help. And giving systemic therapy obviously have some side effects, including it could affect the liver, but they do have some side effects. So the question is, do we really benefit these patients by trying to control the cancer, or we're actually doing more harm? So typically, for these patients, it's not recommended. The only exceptions is if you really think that some of these factors could be reversible, then in Child-Pugh B8, if you look at the guideline, they say, yes, if you think it's something reversible, you can manage your symptoms. And if the Child-Pugh function improves, then you could consider systemic therapy. But in general, systemic therapy is not recommended for this group because we likely cause more harm than good in these patients. For sure. I mean, I think, when you look at these trials, most of these trials accrue Asian population, as many of these studies are done in Asia because hepatocellular cancer is much more common there. And then when you look at in US, again, we look at population which are mainly either Asian or white. And outside of these population, we really have not much data in like African American population where HCC is also there as well, right? We see them in clinical practice, and this is just because of the trial accrual from this setting. And here there's a lot of other differences is like socioeconomic factors, lack of access, travel issue, which definitely affects their survival. So even in our study, we saw that patients with African American had a poorer survival compared to the overall population. And some of these could be affected, definitely be affected, even within the same Child-Pugh score. So some of this was definitely affected by their socioeconomic factors, access to the care, and so on. So I think we have to make efforts to provide our best care in the community setting, right? How do we provide the care near the patient's home? There are other things that can be done from social aspect, is like providing travel to the site where they can get treatment and providing other support. But I think the biggest thing would be to somehow get care, the similar level of care that we can provide at the big academic center in the community setting. There's a clinical trial actually looking at Atezo-Bev is in a prospective fashion, not a randomized trial, but it's like a single arm phase 2 trial looking at Atezo-Bev or even just still Atezo in patients with Child-Pugh B. Obviously, as I mentioned, there's no study which is going to look at Child-Pugh C, but at least there's been an attempt to look at Child-Pugh B and see what kind of outcomes we get. The disparities in care is actually, it's a big issue, not just for HCC, but for other cancers as well. And there are a lot of efforts are being developed to address those issues. And obviously, those are very complex issues and not easily taken care of. So like one of the studies that we got a grant is we are trying to look at biomarker testing for our GI patients and see if we can do more universal testing, because again, in these underserved population. Many times, even the biomarker testing, like simple tests like NGS testing, is not the best. So how do we make it like more uniform? Like, I mean, obviously, most of the centers are developing guidelines. There are national guidelines as well, how patients can be treated. But again, we have to provide them access to the care, and more importantly, like do the relevant testing and then provide the best treatment for these patients.